Medicare and Medicaid were created 61 years ago to protect Americans' health and financial security. On their anniversary, we look at the future of both programs and the growing attacks on Medicaid through the One Big Beautiful Bill Act. In this episode of Care Talk, Margarida of Healthcare for America Now discusses what the present and the future of Medicare and Medicaid looks like for patients, families, seniors, people with disabilities, and everyone who depends on affordable health care. Welcome to Care Talk Live, a weekly American healthcare policy show and podcast where we explain how healthcare works or doesn't work and get you answers. I'm Laura Packard, cancer survivor and healthcare advocate, here to help you. Be sure to subscribe to my channel or podcast wherever you get your podcasts to get future Care Talk shows. Today, we'll examine the fight over Medicaid cuts, paperwork and red tape requirements, access to care, and what advocates can do to protect Medicare and Medicaid for the future. So, welcome to Margarida, the Executive Director of Healthcare for America Now.
Hey, good to see you.
Thanks for coming back to the show. So let's start with, what was healthcare in America like before Medicare and Medicaid were created 61 years ago this week?
Healthcare for people was much harder to access because there were no public programs, which means that, we had an extreme situation of some of the things that prevail today, but essentially there was no way, if you were somebody that didn't have a job that offered insurance, or somebody who didn't have money, to be able to pay for health insurance or health care. And granted, back in the day, the cost of health care was less, obviously, than it is today. But as people age, they use more and more health care. And so especially for the populations that Medicaid is the most important in serving, and that is really older Americans, right? Because Medicare doesn't cover long-term care. So older people, people with disabilities, and children really struggled the most without Medicaid and Medicare. And of course, just like today, having to pay out of pocket for medical expenses, even if those medical expenses were not accelerating in cost in the way that they are today, created a major hardship for people.
So if you go back several decades before these programs existed, people worked until they could not work anymore. And if they couldn't afford care, they died.
Mm-hmm. Right. And life expectancy was much shorter, right? Even in the 60s, well, depending on how old you are, but for somebody like me, that is coming into my seniorhood in the next decade, the expectation these days is that people are going to live a pretty long time. One of the reasons why people can live longer is because they've gotten routine care. Often from the time that they're born, they get routine preventative care. For the United States right now, half of all kids are covered under Medicaid or CHIP, the related Medicaid program. And so having that early childhood access to education, access to healthcare, and having regular preventative care, vaccines, all of those things, dental care, extends people's lives. And so the way that the longevity that people can expect today is much greater than what they could expect, even 25, 30 years ago. It doesn't sound like that long, but it's being extended quite a bit.
And especially for people with disabilities, Medicaid and also Medicare was life-changing.
Mm-hmm.
What was it like before these programs existed? People were, if you couldn't afford care, if you couldn't afford to live in a home, what happened to people?
People just made do as best as they could. But obviously, already, even with all the protections that we have in place, it's already a very challenging burden on families in terms of caregiving and services. For people with disabilities, Medicaid and Medicare, for people that are technically qualified under SSDI as disabled people, it's really incredible. And it was really fueled also by a huge movement for people with disability rights, that people with disabilities should have the ability and the right to live independent lives. So it wasn't, the culture around people with disabilities has changed significantly from, years ago when it was just you had somebody who had the disability, they were locked away in an institution or they were locked away at home and you just did the best that you could, into a culture where really it's much more forward facing from early on in that person's life. What can we do to improve their quality of life and to give them equitable access to the things that everybody else has? And that's why Medicaid, and as you're thinking about the cuts and learning about the cuts, one thing that I think is actually really underrepresented in the Medicaid cuts and the way we talk about it is the impact of those cuts on kids, and especially, for instance, kids in schools, right, who are depending on Medicaid for special education, disability needs in schools. All of that is funded by Medicaid. There isn't a separate school fund for kids that have disabilities that need special services in schools. And that's really represents decades of work of advocates really insisting that children with disabilities have access to the same opportunities, materials, and resources, though, obviously modified to suit their needs in a way that we just didn't have right before the Americans with Disabilities Act, or, back in the 60s and 70s when this movement was just getting started.
Mm-hmm. So that's how things have changed from the past, through the past few decades to today. Let's talk about the changes that are happening right now because of the One Big Beautiful Bill that was passed last year. So already we are seeing changes to Medicaid in some states, and changes are going to be happening to everyone on Medicaid next year, right?
Yeah. So the big change that happened under there were sort of a couple of different layers, but I'll just sort of nutshell it down. Medicaid has expanded tremendously in the United States, partially because of the Affordable Care Act. When the Affordable Care Act, which was passed in 2010, first was implemented, the vast majority of people who gained coverage under the Affordable Care Act gained it through Medicaid expansion in states. It was very popular. Even Republican governors were very eager to expand Medicaid because it is the most efficient way, the cheapest way, and the lowest administrative cost way to provide coverage to people who have no other access to coverage because they may have a job that doesn't offer affordable coverage. They may be a gig worker, they may be a seasonal worker, they may be a student, they may be a caretaker. There's lots of reasons why people would need access to healthcare and not be able to get it on their job. And in fact, one of the biggest challenges in the United States and why Medicaid expansion has become such a powerful policy is because increasingly as the workforce changes, we don't have as many people working a traditional job that's going to offer them family coverage or affordable coverage in the way that we used to. And there's a growing sense that it doesn't make that much sense overall to have healthcare tied to employment. So we had a great expansion in 40 states plus DC of Medicaid. When President Trump took office this time, he was very determined to shrink the Medicaid rolls, frankly. And we know that Republicans often, when they're in charge, Medicaid becomes a target for them. But really what's happened in this second term of the Trump administration is really unprecedented. And one of the unprecedented things was just the size of the cut that the president and the Republicans made in the One Big Beautiful Bill Act. They cut almost $1 trillion, a massive amount from Medicaid. It's the biggest cut in history. And there's going to be cascading impacts. So not only will 10 million people likely lose coverage based on the government's own calculations, but they also made changes to the way Medicaid funds state budgets and the way Medicaid funds hospitals and clinics and nursing homes. And, Medicaid, for people who don't know, Medicaid is a joint state and federal program, right? Medicare is all federally funded. Medicaid, jointly funded. But in most states, the federal government is paying a significant amount, often more than half. And for the Medicaid expansion in states that had millions upon millions of uninsured people before Medicaid expansion, Medicaid actually picked up 100% of the cost of insuring those people. So under the One Big Beautiful Bill Act, this $1 trillion was just slashed in Medicaid. It's going to be implemented over the next 5 or 6 years. And the way that it was done was essentially to try to reduce the Medicaid rolls by attrition by making it a lot harder to access Medicaid. So much harder to sign up, much harder to stay enrolled. It's through this intense paperwork requirement that they have, where people have to qualify by showing that they work a precise number of hours in a particular way, and that they have to show that repeatedly over the course of a year. Well, we know, not just with Medicaid, any insurance. I mean, if you're somebody who has private insurance and you have to sign up for your insurance every year, you have to track what the heck it covers and all that. I mean, it's very difficult to stay on top of it. People in Medicare would say the same, very difficult to keep track of all the moving parts. And so for people in Medicaid, once you're enrolled, having to go back every 6 months or every 2 months or every 3 months or whatever the state decides is going to create a huge challenge in people staying enrolled.
Absolutely. And I think it's important to understand that the folks on Medicaid, the kind of people that benefit from Medicaid right now, are, like I said earlier, gig workers, part-time workers, students, low income people, or people that got sick and lost their job and now need that health care to stay alive. And these are exactly the kinds of people that are maybe in between addresses. Maybe you lost your job, you lost your home, and now you're scrambling to get healthcare. It's going to be hard for people in these difficult situations or multiple gig jobs to be able to stay on top of the paperwork, or if they have to show up in an office in a 9 to 5 Monday through Friday place that is several miles away and they don't have a vehicle, there's going to be all of these red tape that is designed to throw people off their health insurance, even though they need and deserve it.
Absolutely. I mean, if you've ever had a relative, even before Medicaid expansion, even before Medicaid was able to insure low-income working people, even some moderate-income working people, just if you were signing up like your grandma for Medicaid, it is a very complicated process. I mean, I myself have had the experience of, getting my parent covered by Medicaid in the state of Massachusetts, and just like the number of items to track, the amount of phone call, like it's difficult to qualify for Medicaid, even in states that are generous with their Medicaid programs and want more people to be enrolled. So adding more layers to that can only be a ploy to make sure that people can't make it through the process and that they drop out because it's too many moving parts, it's too much paperwork, it's too much to track. And you're exactly right. I mean, people who work in the gig economy, the modern economy, right, they have 2, 3, sometimes 4 jobs, right? They are, if you haven't been in a rideshare, strike up a conversation with your rideshare driver, your Uber driver, your Lyft driver, and they will tell you, well, during the day I do this. And then for these 5 hours, I drive Lyft. And then later on, I'll go pick up my kids, drop off my kids, and then I have a job working, at night. So people are at a time when people really don't have very many options for healthcare because the cost of private healthcare is so expensive. It's not like people are going to get dropped off of Medicaid because they can't fulfill all of the 101 requirements and then go get healthcare on an exchange. That's not going to happen because it's not affordable anyplace else. And many, many, many of these people work for companies that don't offer healthcare and purposely don't offer healthcare because they want to offload their employees' healthcare costs onto the public system. And by that, I'm talking about employers like huge employers like Walmart and Amazon, right? That just won't give their workers full-time hours, won't make the insurance affordable. So at some point, the Medicaid expansion really became a lifesaver and frankly shrunk the number of uninsured people to a record low, and costs in the whole healthcare system went down as a result of that, because when you have more people covered, you are able to reduce costs. It's sort of a game of scale. This rising number of uninsured people that we're going to see, I mean, that isn't saving anybody money, right? Cutting 10 trillion, especially not in this bill, because in this bill, the president cut $1 trillion out of Medicaid and then turned right around and used that $1 trillion to offset the cost of tax breaks for wealthy people, corporations, and shareholders. So it's not like we saved $1 trillion and it's out there somewhere and we're going to deploy it for something else. No, in the same bill. In fact, he cut Medicaid in a tax bill in order to fund these extended tax breaks for people. The folks who are going to really bear the cost of that cut and the rising numbers of uninsured people is going to be the rest of us, right? When there are massive numbers of uninsured people, it's not like the emergency rooms and the healthcare providers don't collect money. It's just that they redistribute that cost by raising rates, raising premiums, and raising costs for the rest of us, right? We saw that in the lead up to the Affordable Care Act, and it was a major reason why so many people, businesses, and average people wanted to see increases in coverage, because when you have millions upon millions of people that are not covered, we still pay for that. Rather than having Medicaid pay for it, we're paying for it directly through our premiums and through and by subsidizing the private system.
Which is one of the least cost-effective ways of doing it. And
Absolutely.
also, it is a lot cheaper to provide preventative care and early treatment than for people to avoid going to the doctor and wind up in the ER with, a heart attack or metastatic cancer or lung failure. The end stage of a lot of diseases, and it just costs everybody taxpayers more money and more human suffering. So we know that these Medicaid cuts are coming, that some states have already started implementing red tape, and that others will start doing it next year. So what does the future of Medicaid and Medicare look like right now?
Well, partially, as you know, it's a political question, right? So this Congress was, had a Republican majority in the House, a Republican majority in the Senate, Republican president. This entire piece of legislation, which ultimately was a $4 trillion bill, if you count up all of the tax breaks and all of the cuts and stuff, was passed without any Democrats. Not one Democrat voted for this piece of legislation. And so the thinking is there's a midterm election coming up. A lot of people are really angry about what has happened with Medicaid. And I think we're going to see that issue pop up in the upcoming election. And I'm already seeing in the next Congress, where we could have a completely different configuration of people, we could have mixed control, but I'm already seeing a lot of lawmakers step up and start talking, not just about how do we reverse some of these cuts and sort of, Band-Aid up a few things, but actually thinking much bigger about how to leverage Medicaid and Medicare in a bigger way, a more permanent way to provide a longer term benefit. And I'll just point to one example. Senator Andy Kim from New Jersey filed a bill last week, and his bill was a proposal to expand, not just undo the cuts, but expand Medicaid much more broadly so that all kids could be covered under Medicaid up until age 26. This is a great idea, exactly because of what you're saying, Laura, because it's a lot of opportunity to invest in kids when they're young and give them an opportunity for better health as they grow and they age. And we know that investing in that way in kids, investing in kids' health, results in a more healthy population over time. And it's exactly true that when you look at the healthcare system, it's pretty remarkable because you see that the greatest share of cost is on a relatively small number of patients that are the sickest patients, right? And even in Medicaid, right? Medicaid right now insures half the kids in the country. There's more kids insured under Medicaid than there are seniors who depend on Medicaid. Yet seniors and people with disabilities make up a greater share of the cost because their healthcare needs are so much more, right? Whereas it's relatively cheap to provide coverage to kids because kids are young and they're resilient, and it's not that they never get sick, but a lot of them, thank goodness, are very healthy. So I actually think that in a way that maybe the president doesn't love, his attack on Medicaid is creating an impetus for people to think more creatively and broadly about how to do more with this program. And that's because President Trump didn't just make this massive cut in the One Big Beautiful Bill Act. He did a bunch of things and also refused to take action on some things that have raised healthcare costs for millions upon millions upon millions of people that have private coverage, that have employer-sponsored coverage. And so healthcare is back in the news. back on people's minds in a much bigger way. And anytime you have that and people are looking for how to get the best quality care, the most coverage with the least amount of cost and the most efficient administration, you have to go to Medicaid. That is the program that has that. We already negotiate rates with providers in that program. It's got the lowest administrative costs of any program in America. So in an ironic way, what the Republicans have done to Medicaid actually opens up a different kind of future, a sort of more urgent attention to healthcare and to Medicaid's role in it, in a way that they probably didn't expect.
Well, thank you very much for joining us, and let's hope for 61 more years and many more for Medicare and Medicaid and healthcare for everyone.
Absolutely. Right you are. Happy birthday to Medicaid and Medicare and many more, and let us have more to celebrate over the coming couple of years.
For sure. And a reminder to everyone that we have free or low-cost healthcare resources available on our website at healthcarevoices.org/caretalk, so check it out. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. And now our experts will answer your health insurance questions. So welcome to Louise Norris, Health Insurance and Healthcare Reform Analyst at healthinsurance.org, and Rachel Madley, the Executive Director of Center for Health and Democracy. So let's start with Rachel and an update on the GLP-1 Medicare Bridge Program.
Thanks so much for having me, Laura. And I wanted to highlight that CMS recently announced a bridge program for coverage of GLP-1 medications on Medicare. Now, this program is going to run from the beginning of this month, July 1st, to December 31st, 2027. Eligible beneficiaries will be Medicare beneficiaries who have been prescribed a GLP-1 for chronic weight management. If you're an eligible beneficiary, no matter what Part D plan you have, which is the prescription drug plans in Medicare, you will have a $50 copay for your GLP-1 per month. Now, it's really important to remember that this is only going to be for specific GLP-1 medications, including Wegovy, Foundayo, and Zepbound, and this is outside of any of your Part D benefits. So this does not, your deductible will not apply here, and no part of that $50 copay per month or $600 per year that you'll end up spending will count towards your out-of-pocket cap of $2,100. So definitely a big step forward, because a lot of people are facing high out-of-pocket costs because GLP-1s are not covered on a lot of Part D plans, but we still have a long way to go because these costs are not counting towards the out-of-pocket cap.
Thanks, Rachel. And now a question from B143441, who wants to know, where do I file a complaint about receiving a good faith estimate from the hospital to be only $200? The estimate assumed that insurance would cover the bulk of the costs, but when the claim was filed, the insurance did not and charged it against the deductible. So this was a surprise. It was a scheduled outpatient scan, not an emergency. So, Louise, can you tell us more about what's going on and what they can do, if anything?
Sure. So, unfortunately, there probably is not going to be a lot of recourse here. The No Surprises Act, it has a few different parts to it. It protects people in emergency situations, which this was not. It also protects people who go to an in-network hospital or medical facility, but then end up getting, unknown to them, treated by an out-of-network provider, maybe an anesthesiologist, a radiologist, someone like that, who in the past, you would have had an out-of-network charge even though you were at an in-network facility. That's not allowed under the No Surprises Act. But what this person is referring to is the good faith estimate part of the No Surprises Act. But that only applies to people who don't have insurance, or who, for one reason or another, aren't going to run the procedure through their insurance. If you're paying cash, the No Surprises Act has a provision that allows you to get a good faith estimate from the hospital, and then that is relatively binding. In this case, that was not what was happening here. And unfortunately, it is up to you to make sure you understand your insurance benefits. So going forward, I would recommend, if you're in a situation like this, you need to call your insurance, not the hospital, because the hospital doesn't have access to, like, for example, how much your deductible is, whether you've met any portion of your deductible so far this year. Like maybe you have a $5,000 deductible, maybe you've already met it somewhere else at another facility. Obviously, the hospital wouldn't know that, but your insurance would know that. So in the future, if you are going to have a procedure and you are going to run it through insurance, your health plan is going to be the one you're going to need to talk to, and they will be able to explain to you, what your deductible is, whether you've met any of that deductible yet at this point. So in this case, it sounds like there was a $3,000 deductible. You have to meet that before you get any sort of payment, before the insurance will pay anything for any services that are subject to the deductible, which is most services. There's a small off chance that you could contact your health plan and the hospital and see if maybe any errors were made. It's possible this was a service that wasn't supposed to count towards the deductible, and it's possible an error was made, but I doubt it. I would guess that, like I say, most services that you receive in a hospital, you do have to meet your deductible first. And it sounds like in this case, the deductible had not been met. So just probably not much you can do on this one, but just going forward, your insurance plan is who you need to contact, not the hospital, if you're going to run it through insurance.
Thank you, Louise. And now a question from Naive Bat 826, who says that I think a lot of folks are under the impression that once you're on Medicare at age 65, you're no longer at risk of financial ruin due to medical costs. But is that true? If you get a serious diagnosis of cancer or other long-term chronic illness or car accident or heart attack, how much of a protective shield does Medicare actually provide seniors for serious medical conditions? Rachel?
This is a great question. And in terms of the protective shield, there are a lot of things that go into it. So if you are on traditional Medicare, for Medicare Part A, your hospital services, you may have high out-of-pocket costs. That can be a deductible of $1,736 each time you need care during hospitalization. And after that, if you are in the hospital for more than 60 days, you will have an additional coinsurance payment per day. For Medicare Part B, this is outpatient services, think a doctor's visit. You will have a deductible of $283 per year. And after that, you will have to pay 20% of the Medicare reimbursement rate for doctor's visits and those other outpatient care needs. Now, for Part A and B, there is not an out-of-pocket cap as there is in every other health insurance plan. And so if you don't have a supplemental plan, also known as a Medigap plan, which you can layer on top of traditional Medicare, your out-of-pocket costs can be unlimited if you do have a serious health event such as cancer or an accident. When you're looking at prescription drug coverage under Medicare Part D, the out-of-pocket costs vary by plan. There is an out-of-pocket cap there. So the most you will spend in a year on your prescription drugs is $2,100, thanks to the Inflation Reduction Act. Now, if you have Medicare Advantage coverage, you're still going to have very high out-of-pocket costs. There is a roughly $5,000 out-of-pocket cap for Parts A and B. So you will have, up to $5,000 for that care, and then the separate prescription drug out-of-pocket cap of $2,100 per year. Now, Medicare Advantage does come with a lot of care restrictions, like narrow networks and prior authorization. And I mention that because in a case of a life-threatening event or a serious medical event like cancer, those narrow networks and prior authorization requirements are going to matter a lot. A lot of National Cancer Centers of Excellence are actually not in any Medicare Advantage networks. And so you might end up paying even more out of pocket when you need serious medical care. So, all of that being said, Medicare is definitely a protective shield against high healthcare costs, especially if you're able to have traditional Medicare with a Medigap plan on top of it, because that Medigap plan will limit or remove all of the cost sharing that I mentioned under Medicare Parts A and B. I also want to flag that there are steps being taken to add an out of pocket cap to traditional Medicare. And just last month, Senators Blunt, Rochester, Wyden, and Schumer introduced the Medicare Cost Cap Act, S4886, and that would for the first time establish a $5,000 out of pocket cap for hospital and medical services covered under Part A and B. So Medicare is a shield, but it takes a lot of understanding of the different parts and making sure you have the right plans lined up to make sure that it is protecting you against high out of pocket costs.
Thank you, Rachel. And thank you to everyone for joining us to learn more about healthcare policy, patients' rights, the fight for a just healthcare system, and answers to your questions on health insurance and healthcare. Be sure to check out more free or low-cost healthcare resources on our website at healthcarevoices.org/caretalk. Please text or call in your health insurance and healthcare questions at 202-838-6837, and we'll answer them in future episodes. Join us next week for more. Be sure to subscribe to my channel or podcasts wherever you get your podcasts. My name is Laura Packard, and this is Care Talk.